All right, so a very good evening, everyone. So in this particular section, I will be discussing the adrenal gland disorders. Right, 1 minute. Right. So I'll be discussing the adrenal gland disorders. So in the adrenal gland disorders, I'll be discussing the Cushing syndrome, the Addison's, and then the pheochromocytoma. So I'll be discussing the new updates also in these particular disorders. Just 1 second, guys. Okay. So I'll be discussing the new updates in the treatment, and I'll also be showing you some of the important multiple choice questions of the same topic. Right. Now, first coming to the important scenario, that is the Cushing syndrome. So what exactly is the problem in these patients with the Cushing syndrome? It is the disorder which is characterized by the excess glucocorticoids. It is the disorder which is characterized by the excess glucocorticoids. And this Cushing syndrome, it can be either ACTH dependent or it can be ACTH independent. ACTH dependent or the ACTH independent. Now, you take this ACTH dependent etiologies that includes the corticotroph type of pituitary adenoma or the ectopic ACTH sources. What are the ectopic ACTH sources? The most common cause for the ectopic ACTH sources will be the small cell carcinoma of the lung, which is also called oat cell carcinoma. And the another important the ectopic causes will be adrenal pheochromocytoma. And another important ectopic source will be the carcinoid syndrome. Right? So this carcinoid, it will be bronchial carcinoids. And then medullary carcinoma of thyroid. Right? Medullary carcinoma of thyroid. So these are the ectopic sources for the ACTH dependent cause for Cushing's. Then we have ACTH independent causes. ACTH independent causes, they are not dependent on the ACTH which is coming from the anterior pituitary. They are mainly the tumors of the adrenal gland, and the most common cause will be the adrenal adenoma. The other etiologies will be adrenal carcinoma. Right? So most common cause for ACTH independent will be your adrenal adenoma. But overall, what is the most common cause for the Cushing syndrome? The most common cause for the Cushing's will be the iatrogenic. And if you take the incidence, this is nearly around 1 to 2 per 1 lakh population per year. And this Cushing syndrome, this is more common in women. Right? This is more common in women, except in the prepubertal cases. Except in prepubertal cases, where it is common in boys. Right? In post-puberty, it is more common in women, but in the prepubertal cases, it is more common in boys rather than the girls. Now, you take this pituitary adenomas, corticotroph type of pituitary adenomas are the one which are ACTH dependent cause for Cushing's. And what is the mutation that will be responsible for the corticotroph type of pituitary adenoma is the USP8 mutation. That is what is contributing to corticotroph type of pituitary adenoma. Then ectopic causes, as I was discussing, the carcinoid tumors. Then ACTH independent, that includes the adrenal adenomas. Now, in order to develop adrenal adenoma, what is the mutations? The mutations are the PRKACA mutations that is observed in 40% of patients, and some of the rare cases, the mutations include the ARMC5 mutation, then PRKAR1A mutation, then McCune-Albright syndrome, that is GNAS1 mutation. That is GNAS1 mutation. Okay, so these are the causes for the development of the Cushing syndrome. And if you take the clinical manifestation in these individuals, what is the earliest clinical manifestation in patients with the Cushing syndrome? Right, that will be weight gain. Right, the earliest manifestation in patients with the Cushing syndrome will be weight gain, and next the central obesity. And there will be redistribution of the free fatty acids that will be responsible for central obesity, that will be responsible for moon-shaped facies as well. And why there will be purple striae? Because of the redistribution of the free fatty acids in the abdomen, there will be subcutaneous accumulation of the free fatty acids and there will be stretch of the skin. And that will result in the purple striae. Next important is the hypertension. Now, what is the reason for the development of the hypertension? Because glucocorticoids, they upregulate the alpha-1 receptors on the blood vessels. They upregulate the alpha-1 receptors on the blood vessels and they increase the sensitivity of the catecholamines and that will result in development of hypertension. And why there is osteoporosis? Because glucocorticoids, they have increased osteoclastic activity. They increase the bone resorption. When the levels are increased in Cushing's, that will result in osteoporosis that will be responsible for pathological fracture. And hyperglycemia, why? Because glucocorticoids, they increase hepatic gluconeogenesis and that will result in hyperglycemia in patients with the Cushing's. They are at increased risk of psychiatric symptoms and the hypercoagulability. Then how will you confirm the diagnosis? So it is confirmed by 24-hour urinary free cortisol levels that will be elevated, right? And another important screening test or the confirmatory test that we can do is 1 milligram overnight dexamethasone suppression test, where early morning cortisol levels will be on the higher side in patients with the Cushing syndrome, right? And even what will happen to your midnight cortisol levels in the saliva? Midnight salivary cortisol levels, they are elevated. Midnight salivary cortisol levels, they are being elevated. Now, normally, in a normal person, what should happen? In a normal person, the midnight cortisol levels should be low. But in these patients with the Cushing's, the midnight salivary cortisol levels are being elevated. That is what is nothing but the loss of diurnal variation. There will be loss of diurnal variation in these patients. Okay. And the next important investigation will be the ACTH levels that are very important. And these ACTH levels will help us to differentiate whether it is ACTH dependent or the ACTH independent. Now, in case of the ACTH dependent, that is pituitary adenomas or ectopic causes, the ACTH levels will be on the higher side. Whereas ACTH independent, the ACTH levels will be reduced, right? Now, in the ACTH dependent, we have corticotroph type of pituitary adenoma, and then you have ectopic causes. So to differentiate these two, what we need to do is the petrosal sinus sampling has to be done. Right? Petrosal sinus sampling has to be done to differentiate these two, right? Now, one of the very important differential diagnoses is the pseudo-Cushing state. Where do you have pseudo-Cushing's? That is observed in case of the alcoholism, right? That is observed in the medication effects. What are those medications which will give you the picture of the Cushing's? Will be the oral contraceptives and then CYP3A4 inducers. These are the two important medications which will give you a Cushing's-like picture, right? So these two are your differential diagnosis, pseudo-Cushing states and as well as the medication effects. Next, coming to the imaging. So if you see the imaging, it is the MRI for the pituitary lesion. MRI for the pituitary lesion, that is corticotroph type of pituitary adenoma. Then you need to do CT scan for adrenal tumors, that is adrenal adenoma or adrenal carcinoma. And you need to do the octreotide scintigraphy test, that is mainly for ectopic sources like small cell carcinoma, right? And then inferior petrosal sinus sampling for the ACTH gradient. So when you do an inferior petrosal sinus sampling, right? And then you take, so inferior petrosal sinus sample ACTH and the peripheral ACTH levels, right? Then peripheral ACTH levels. If the ratio is more than 2:1, that is suggestive of corticotroph type of pituitary adenoma. Then how do you treat these patients with the Cushing syndrome? That is all dependent on where is the source of the Cushing's. Now, suppose if it is ACTH independent, that is adrenal adenoma or adrenal carcinoma, then you need to do the adrenalectomy. If it is Cushing's disease, that is like pituitary adenoma causing Cushing's, right? Pituitary adenoma is causing Cushing's. Then in such case, you need to do transsphenoidal pituitary adenectomy has to be done, right? Now, in those individuals where the surgical treatment is contraindicated or if the individual is not willing for surgery, then medical management has to be given. And within the medical management, drug of choice is the ketoconazole, and this ketoconazole, it is an adrenal enzyme inhibitor. So in that way, that is given as a treatment. So ketoconazole, and the other important molecule is the metirapone, and we have a new molecule, that is the osilodrostat. This is a new trial, this is a new treatment, the osilodrostat. It's a new molecule given in the treatment of the Cushing's. The other one is the metotane. Then how do you treat ectopic ACTH sources? In such case, you need to do tumor resection, or you need to give chemotherapy for that particular tumor. But whenever you do this bilateral adrenal gland resection, there is chance of development of Nelson syndrome, because whenever you do bilateral adrenal gland resection, what will happen to your cortisol levels? The cortisol levels are being reduced, right? When you do bilateral adrenal gland resection. Now, once okay. So once the cortisol levels are reduced, what will happen to the ACTH levels? There will be increase in the ACTH levels. Once there is increase in ACTH, parallelly there will also be increase in MSH, and that will result in the pigmentation. So Nelson syndrome is nothing but hyperpigmentation after bilateral adrenalectomy. Hyperpigmentation after bilateral adrenalectomy due to increase in ACTH. That is what is called as the Nelson syndrome. Okay. Now, let me tell you the important new trials in the treatment of the Cushing's. So one of the new molecule that I was telling you is about the osilodrostat. Basically, it is a 11-beta hydroxylase inhibitor, right? And what is the advantage of this osilodrostat is it will be reducing the cortisol levels effectively. But the common side effect is it can cause adrenal insufficiency. So this is one of the new molecules, that is osilodrostat, which will inhibit 11-beta hydroxylase enzyme. Then we have new molecules in the trials which have come up, that is levoketoconazole, right? So levoketoconazole, it is a steroidogenesis inhibitor. Even this will also inhibit the enzymes which are required for the synthesis of the cortisol. So how will you make out the effect of this levoketoconazole is when you check the urinary free cortisol levels, they are being reduced, right? And this particular levoketoconazole, it is effective in managing the hypercortisolism, and it has been approved in December 2021. So this is about levoketoconazole. Then the another important new molecule is Relaco. The other new molecule is Relacorelant. This Relacorelant, it is a glucocorticoid receptor inhibitor, right? And what is the advantage of this particular Relacorelant? It is having a sustained cardiometabolic improvement, and it is well tolerated up to 6 years, right? And it has a promising long-term treatment with this Relacorelant, so which is a new molecule. And another important new molecule for the treatment of the Cushing's is the peceriotide, which is actually somatostatin analog, right? And the advantage of this peceriotide is it has a very good improved clinical signs and as well as symptoms. And this peceriotide, it is effective in reducing the cortisol levels. It is effective in reducing the cortisol levels. That is the advantage of this peceriotide, right? Then next important is the SPI62, which is the HSD1 inhibitor, right? And this potent inhibition of the HSD1, it has clinical development which is ongoing, and it is a new therapeutic option. Which one? The SPI62. Okay, so this is about the new molecules in the treatment of the Cushing's. That includes the osilodrostat, then levoketoconazole, Relacorelant, then peceriotide, then SPI62, right? Now, so this was completely about the Cushing syndrome. Now, let me discuss some of the MCQs related to Cushing syndrome. Okay, so I want the active participation from you all. So a 42-year-old woman presents with the weight gain. There is also moon phases and the purple striae. What is the next best test to determine the cause? Serum ACTH, high dose dexamethasone, bilateral adrenal CT, then MRI of the brain. Yes. Yeah. What is the next best test to determine the cause? So what is that you have to do in this individual is you need to do the serum ACTH levels. The serum ACTH levels, that is the one which will determine whether it is ACTH dependent or the ACTH independent. Right? ACTH dependent or the ACTH independent. Okay. So that is the next important test. Okay. Next question. Right. We have a 55-year-old smoker presents with hyperpigmentation and as well as the hypertension. ACTH and cortisol levels are high and they do not suppress with dexamethasone. What is the most likely cause? Pituitary corticotroph type of adenoma, adrenal adenoma, ectopic ACTH production, then primary adrenal hyperplasia. Yes, any one of you? Right. So here the point is ACTH and cortisol levels both are high. That means ACTH levels are also elevated. If ACTH levels are also elevated, what type of the pituitary adenoma is this? Sorry, what type of Cushing's is this? It is ACTH dependent type of Cushing's. So in ACTH dependent type of Cushing's, we have one pituitary adenoma and the second one is ectopic ACTH. Now among these two, corticotroph type of pituitary adenoma and the ectopic ACTH, the cortisol levels are high, do not suppress with dexamethasone. Do not suppress with dexamethasone. What is the most likely cause? The most likely cause will be the ectopic ACTH production. In ectopic ACTH production, you don't have the suppression in spite of the high dose dexamethasone. Okay, so this is about the Cushing, the investigations in Cushing's. Right. Another question. 30-year-old women with central obesity and the osteoporosis has 3 mm pituitary lesions. The inferior petrosal sinus sampling shows central to peripheral ACTH ratio of more than 3. What is the most likely diagnosis in this scenario? Cushing's disease, ectopic ACTH syndrome, adrenal adenoma, then pseudo Cushing syndrome. Right? Pseudo Cushing syndrome. Okay, so here the individual is having the features of the Cushing's, where there is central obesity, then osteoporosis, and 3 mm pituitary lesion. And inferior petrosal sinus sampling shows central to peripheral ACTH ratio more than 3. What is the most likely diagnosis? So here, the central to peripheral ACTH ratio is more than 3. That is suggestive of the pituitary adenoma. That is suggestive of the pituitary adenoma. Now, if it is pituitary adenoma, it is called as the Cushing's disease. Right? Cushing syndrome is different from Cushing's disease. We use the terminology Cushing's disease only for pituitary adenoma, whereas we use the terminology Cushing syndrome for all the etiologies which are causing the Cushing's. Okay, so because central to peripheral ACTH more than 2, if it is there, it is suggestive of your pituitary adenoma, and here the answer is the Cushing's disease. Right? Next question. Okay, so a patient with ACTH independent Cushing's undergoes right adrenalectomy and later develops hypotension. What is the most likely cause in this patient? ACTH independent Cushing's undergoes right adrenalectomy and later develops hypotension. What is the most likely cause in this patient? Addison's, adrenal crisis due to suppressed contralateral adrenal gland, then the residual ACTH secreting tumor, Nelson syndrome. Yes, what is the answer in this? So in these patients after adrenalectomy, the individual has landed up in the severe form of hypotension. So what is this suggestive of? This is suggestive of the adrenal crisis due to suppressed contralateral adrenal gland. Right? It is adrenal crisis due to suppressed contralateral adrenal gland. All right. So the answer is B in this question. Okay, then we will move on to, it is not Addison's. Why don't you consider this as Addison's? Why? Because the etiology for Addison's is not adrenalectomy. The etiology for Addison's will be autoimmune adrenalitis, or it might be tuberculosis or fungal infections, right? But it is not due to adrenalectomy. So your Addison's is ruled out, right? And residual ACTH secreting tumor, we don't, once you have done adrenalectomy, there is no point of residual ACTH secreting tumor. And if there is ACTH secreting tumor, you will not have hypotension. You will not have hypotension. Okay. And the next important is Nelson's. Nelson's, what did I discuss? It is the hyperpigmentation after bilateral adrenalectomy is what is called as Nelson's. Okay. So the answer in this question is B. Okay. Next question. Right. So we have a 50-year-old woman with the Cushing's disease undergoes bilateral adrenalectomy. Months later, she develops hyperpigmentation and rising ACTH levels. What is the most likely diagnosis? Undergoes bilateral. Here the answer is the Nelson syndrome. It is a hyperpigmentation after bilateral adrenalectomy, and there is increase in ACTH and increase in MSH. Done? Now, after having discussed about the Cushing's, then we will discuss about the Addison's disease. Right? We will discuss about the Addison's disease. Okay. So in case of Addison's, what exactly is the problem? Right? So the problem is that there will be decrease in cortisol, decrease in aldosterone, and there will be decrease in the weak sex hormones. Decrease in cortisol, decrease in aldosterone, and decrease in weak sex hormones. This is what is the problem in case of the Addison's. And we have primary and secondary adrenocortical insufficiency. We use the word Addison's only for primary adrenocortical insufficiency. Right? We use the word Addison's only for primary adrenocortical insufficiency. And what is the difference between primary and secondary is, in primary, there is damage to the adrenal gland. Whereas in secondary, there is damage to the hypothalamo-pituitary dysfunction. Right? And in case of the primary adrenocortical insufficiency, all the hormones are reduced. Your steroids are reduced, then aldosterone is reduced, then weak sex hormones are also reduced. That is in primary adrenocortical insufficiency. Whereas in secondary adrenocortical insufficiency, the steroid levels will be reduced, aldosterone levels will remain normal, and weak sex hormone levels, they are reduced. That is in secondary adrenocortical insufficiency. Okay, that is what is the difference between primary and secondary adrenocortical insufficiency. And what about the chances of the Addison's as such? The adrenal insufficiency, it is one of the rare scenario, right? Among all the etiologies, the autoimmune causes, they predominate the etiologies. Okay, so what is the most common cause for the Addison's? It is autoimmune adrenalitis. That is the most common cause, right? But apart from that, even the genetic disorders and infections, they play the significant role in the development of the Addison's. Then, whereas in India, the autoimmune adrenalitis it is the most common cause for Addison's in the West. Whereas in India, the most common cause will be the tuberculosis, right? And that will lead to the adrenal destruction. Then, among the fungal infections, it is your histoplasmosis, which will infiltrate the adrenal gland, and that will cause the adrenal insufficiency, right? And among the viral infections, it is cytomegalovirus and as well as the HIV. Cytomegalovirus and HIV. That can lead to the adrenal failure. That can lead to the adrenal failure, especially in the immunocompromised individuals. Especially in the immunocompromised individuals. Okay. Then next we have what is called the X-linked adrenoleukodystrophy. X-linked adrenoleukodystrophy. X-linked adrenoleukodystrophy, it is the adrenal insufficiency which is more common in males rather than females, right? And this X-linked adrenoleukodystrophy, this is mainly due to defective peroxisomal function, right? So this is due to defective peroxisomal function, right? And what are the clinical features? That is mainly because of glucocorticoid insufficiency, because of aldosterone insufficiency, and weak sex hormone insufficiency. So they include fatigue because ATP synthesis does not occur due to inefficient gluconeogenesis, right? Weight loss, hypotension, and hyperpigmentation is observed in case of primary. Because in primary adrenocortical insufficiency, the steroids are reduced, and as the steroids are reduced, the ACTH levels are increased from the anterior pituitary, and that will further increase the MSH, and that will cause the hyperpigmentation, right? And there will also be electrolyte abnormality. What will be that electrolyte abnormality? The electrolyte abnormality will be in the form of the hyponatremia and hyperkalemia. Why? Because aldosterone insufficiency is there. Aldosterone is not there here, right? So electrolyte abnormality, hyponatremia, hyperkalemia, and postural hypotension due to the aldosterone deficiency, right? And then hyperpigmentation, why? Due to increase in the MSH levels. Then we have the acute adrenal crisis, right? Acute adrenal crisis. So this is a life-threatening emergency which is requiring immediate glucocorticoid and fluid resuscitation to prevent the fatal outcomes, right? A life-threatening emergency requiring immediate glucocorticoid and fluid resuscitation to prevent the fatal outcome. And one of the very important acute adrenal crisis is the Waterhouse-Friderichsen syndrome. And it is the adrenal hemorrhage due to Neisseria meningitidis, right? Adrenal hemorrhage due to meningococcal infection, that is Neisseria meningitidis, right? And in these patients with the Waterhouse-Friderichsen syndrome, the drug of choice will be intravenous hydrocortisone, right? Intravenous hydrocortisone in acute adrenal crisis. Whereas in Addison's, you don't require IV hydrocortisone. Oral hydrocortisone is also fine. Then, how will you diagnose this Addison's? The investigation of choice will be the cosyntopin test. The investigation of choice will be the short cosyntopin test that remains the gold standard. That remains the gold standard. Okay. And once you do this, the another name for cosyntopin test is, it is also called as synactin test, right? Or this is also called as ACTH stimulation test, right? This is also called as the ACTH stimulation test. Okay, so this is about the cosyntopin test. Now, what will be the result of the cosyntopin? You need to give cosyntopin. How much? 250 micrograms of the cosyntopin has to be given, right? This 250 micrograms of cosyntopin, it should be given either IV or IM, which is an ACTH analog. What should be the response? There should be increase in serum cortisol, right? There will be increase in serum cortisol, right? And this increase in serum cortisol, it should be more than 500 nanomoles, right? It should be more than 500 nanomoles. Okay, that is considered to be normal. But if the increase in cortisol is less than 500 nanomoles, right, then it is considered to be Addison's, right? Then it is considered to be the Addison's. All right. So that is about cosyntopin test, which is the gold standard test. Then how do you treat these patients? So both glucocorticoid and mineralocorticoid replacement is essential in the management. So what is that particular drug which is having both glucocorticoid and mineralocorticoid property? Is hydrocortisone. So hydrocortisone, it is the drug of choice in case of primary adrenocortical insufficiency, that is in case of Addison's. Whereas if you see in case of secondary adrenocortical insufficiency, in secondary adrenocortical insufficiency, you don't require the aldosterone, you require only steroid. So you need to give a highly potent steroid. And what is that highly potent steroid? That is dexamethasone. So in secondary adrenocortical insufficiency, dexamethasone is the drug of choice. But for primary adrenocortical insufficiency, the hydrocortisone is the drug of choice. Okay, because it has both mineralocorticoid and glucocorticoid activity. Then how will you do the monitoring once you start the treatment? That is by clinical assessment, the electrolyte levels, whether they are getting normalized or not, and what will happen to plasma renin levels. Why? Because you take in case of primary adrenocortical insufficiency or you take secondary adrenocortical insufficiency, there will be hypotension. And because of hypotension, there will be increase in renin levels. Once you start the replacement, the renin levels should get normalized. Okay, next, in case of the pregnancy, so hydrocortisone doses may need adjustment in late pregnancy, right? Hydrocortisone doses, they will require adjustment in the late pregnancy. Whereas the adrenal androgen replacement, what is required is dihydroxyepiandrosterone acetate. DHEA stands for dihydroxyepiandrosterone acetate, right? So the patients may benefit with this dihydroxyepiandrosterone acetate supplementation, right? And this supplementation is particularly required in case of women with persistent fatigue and low libido. So that is about adrenal androgen replacement. So it is required in those individuals having decreased libido and persistent fatigue, and particularly in case of women. That is about the treatment in case of the Addison's. Now, let me discuss some of the trials in the Addison's disease treatment. Some of the important trials in the Addison's disease treatment. Okay. So we have one important trial called the Pulsus trial. What is this Pulsus trial? This will tell you that pulsatile cortisol infusion pump. Pulsatile cortisol infusion pump, right? So this is one of the randomized controlled clinical trial. So in these patients, when you give pulsatile cortisol infusion pump, there is improvement in the symptoms of the patient. That is what is your Pulsus trial. The next important is the continuous subcutaneous hydrocortisone. So this is also a RCT, right? So whenever you are giving this continuous subcutaneous hydrocortisone infusion, this mimics, right? This mimics physiological serum cortisol rhythm, right? And this is alternative to the conventional therapy. This is alternative to conventional therapy, right? Next, the other important trial is modified release hydrocortisone therapy. Modified release hydrocortisone therapy. So what is the role of this modified release hydrocortisone therapy is, even this closely mimics the physiological cortisol rhythm. And this has been found to improve the health and quality of the life of the individual, right? And another important replacement is dihydroxyepiandrosterone acetate replacement. And what is the new molecule? That is prasterone, right? So this prasterone, it has been evaluated and it has been shown a very good replacement therapy, mainly in women with loss of libido and persistent fatigue, right? So that is about the prasterone replacement, right? And now let me discuss some of the MCQs on the Addison's. MCQs on the Addison's. Okay. So you see this first question, right? So we have a 45-year-old presents with fatigue, then weight loss, postural dizziness, hyperpigmentation of the skin. Laboratory investigation reveal hyponatremia, hyperkalemia, and low cortisol levels. What is the most likely cause of this condition? Hypopituitarism, the adrenal tuberculosis, Sheehan syndrome, then exogenous steroid withdrawal. Weight loss, postural dizziness, and hyperpigmentation. Hyponatremia, hyperkalemia. What is the most likely cause? So first of all, what is the clinical scenario? Right. First of all, what is the clinical scenario here? The clinical scenario here is suggestive of the Addison's. The clinical scenario is suggestive of the Addison's. right? Why? Because there is weight loss, hyperpigmentation, hyponatremia, hyperkalemia. And what is the most common cause of the Addison's? The most common cause of the Addison's will be the adrenal tuberculosis, right? So the answer here is the adrenal tuberculosis. Okay. Next question. A patient is diagnosed with the adrenal insufficiency after the ACTH stimulation test shows low cortisol response, right? Diagnosed with adrenal insufficiency after an ACTH stimulation test shows low cortisol response. Which additional finding would help differentiate primary from secondary adrenal insufficiency? Right? Which additional finding would help differentiate primary from secondary adrenal insufficiency? Yeah. So the presence of pigmentation, elevated aldosterone, decreased plasma renin activity, normal ACTH levels. So what is the answer? The answer is the presence of the hyperpigmentation. So presence of hyperpigmentation, it is a feature of the primary adrenocortical insufficiency, right? The pigmentation is not observed in secondary adrenocortical insufficiency. Pigmentation, it is not observed in secondary adrenocortical insufficiency. And elevated aldosterone levels is not the feature. In fact, there will be decrease in aldosterone levels in primary, and in secondary it remains normal, right? And decreased plasma renin activity, right? Decreased plasma renin activity will not be there. There will be like these patients, they'll have increase in the plasma renin activity. And ACTH levels, normal ACTH levels, no. In primary, ACTH levels are elevated. In secondary, the ACTH levels are low. Okay, so the answer is A here, right? Next question. Okay, so we have a 30-year-old woman with autoimmune thyroiditis presents with fatigue, nausea, and dizziness. Labs reveal hyponatremia and hyperkalemia. Which additional test is most appropriate to confirm the Addison's? Serum renin and aldosterone, random serum cortisol levels, serum TSH and free T4, then urinary catecholamine levels. There is autoimmune thyroiditis, and the patient is also having hyponatremia, hyperkalemia. Which additional test is most appropriate to confirm the Addison's? Right. So the individual is having autoimmune thyroiditis. So there is a very high chance that the individual is associated with other autoimmune conditions also. What are you suspecting the other autoimmune condition here? The autoimmune adrenalitis. Why? Because the patient is having hyponatremia, hyperkalemia, and there is also dizziness. Now, if I want to confirm the Addison's, what I have to do is I have to check the serum renin and the aldosterone levels. Why? Because in case of the Addison's, the serum renin levels will be elevated, right? The serum level levels elevated, and the aldosterone levels will be low. Aldosterone levels will be low. Okay. Random serum cortisol levels. Random serum cortisol levels, this will not help us to tell it is exactly Addison's, because the random serum cortisol levels, they are reduced both in primary and secondary adrenocortical insufficiency. Then what is Addison's actually? Addison's is only primary adrenocortical insufficiency. So we will not be able to differentiate primary or secondary based on serum cortisol levels, right? The TSH and T4 levels will not tell you about the Addison's. This will tell you only about the thyroid abnormality. And urinary catecholamine levels, they are important in patients with the pheochromocytoma, but not in case of the Addison's, right? Next question. Okay, so a patient with the chronic adrenal insufficiency is admitted with fever, vomiting, and hypotension. What is the most appropriate, the initial management? IV hydrocortisone and rapid saline infusion, IV hydrocortisone and glucose infusion, intramuscular dexamethasone and sodium restriction, intravenous ACTH, and the electrolyte correction. So the individual is having chronic adrenal insufficiency. Now she admitted with fever, vomiting, and hypotension. So what has happened now? the patient is actually having chronic adrenal insufficiency, but this particular fever might have precipitated the ongoing adrenal insufficiency, where the individual has gone into a state of acute adrenal insufficiency. So what is the most appropriate initial management? So the most appropriate, the initial management will be, you need to give rapid IV hydrocortisone. Along with that, saline infusion has to be given, mainly to prevent the cardiovascular collapse. Mainly to prevent the cardiovascular collapse. Why are you giving hydrocortisone? Because it is having a dual property. It has the mineralocorticoid property and it also has glucocorticoid property, which can increase the blood pressure of the individual. Right? So the answer is the IV hydrocortisone. Right? So okay, last question. A 10-year-old boy presents with the progressive neurological decline and the adrenal insufficiency. Genetic testing reveals a mutation in the ABCD1 gene. What is the most likely diagnosis in this patient? Sheehan syndrome, autoimmune polyendocrine syndrome type 2, X-linked adrenoleukodystrophy, Waterhouse-Friderichsen syndrome. So there is neurological decline. That is very important point. Along with that, genetic testing is revealing the mutation ABCD1 gene. So what is this suggestive of? In which condition where you have ABCD1 gene being mutated? That is in case of the X-linked adrenoleukodystrophy. So X-linked adrenoleukodystrophy, you have this ABCD1 gene being mutated. ABCD1 gene being mutated. Okay. So the answer is C here. The answer is C here. Okay. So this finishes the Addisons. So with this, I'm done with the today's topic. Like pheochromocytoma is there. I'll be doing that in the subsequent sessions tomorrow. Okay. So with this, I'll wind up the today's session. Thank you very much. See you tomorrow at 6 p.m.